20 minutes we're gonna be back because I gotta go drink some water or something. These vitamins are like sitting on my stomach, and we'll be back and y'all will be here with us at this appointment and y'all hear everything that we hear. All right, love you guys. Hello?
Hello, is that Danisha?
Yes, this is her.
Hi, Danisha. This is Dr. Peter. How are you?
Good, how are you? I'm so excited and nervous.
Okay, so Danisha, I'm well, thank you. I've just been reading all about you, and I have obviously the copy of the records of it that you uploaded, okay, which are really useful to have, okay? Brilliant, okay? So obviously, guys, I can see this has been a very, very long journey, okay? And that your past has been natural conceptions by, a total of 5 it looks like from the records, okay? And the first 4 of these were early miscarriages.
Yeah.
By the look of what was written, just to check, Danisha, that these were in 2010, 2013, a couple in 2014, and you had done a pregnancy test, but this is before you got to go for initial scans or anything like that. Is that correct?
Correct.
And then obviously since 2014, then you didn't get pregnant for 5 years. I can see that was when they did a number of tests. We'll come back to that. And then you did get pregnant again in 2017, but this ended up being an ectopic pregnancy, was it?
Correct.
And did they have to do surgery, or was it that they could treat you with the injections?
Oh, they had to do surgery.
Okay, and then was that the left tube?
Is that what?
The left tube.
Was that the left tube?
Correct.
Okay, and they removed the tube?
Yes, I lost the tube.
Okay. And if I go back through the records, Danisha, obviously when they initially were working things up in sort of 2015, 2016, they were trying to understand maybe why you were having a number of miscarriages for someone of your age, and they had identified you had what's called a unicornuate uterus. Okay? So our uterus forms embryos ourselves in a funny way where it's almost like 2 halves that join together.
Right.
There are a small percentage of the population that have only one of those halves that function fully, okay?
Right.
And in the record, it was clear. Obviously, don't have the raw films or anything, but it was that you had one half of the uterine segment and with a left tube.
Correct.
When they went in for your surgery for your ectopic, did they confirm what they had seen at the HSG?
At the ectopic pregnancy, they did, but when they went in for the fibroid, is when he saw. I think I put that in the notes. Is that in there? When they did the fibroid. No. Okay, so I had a fibroid the size of a soccer ball, and so when they went in to get the fibroid out, that's when he said my uterus expanded and he found a right tube.
Right.
So.
Okay. All right. So they were not visualizing that, and that would sort of fit that sometimes if someone has it, because I can see that they've been measuring these fibroids in the records, because it's all written as sort of one ongoing line, okay?
Right.
So when did you have that surgery for the fibroid?
So the ectopic removal was in July, August. I want to say September, maybe August. September, I think. Is when it's on the record somewhere. September is when they took the fibroid.
Okay, and so when they went into the ectopic, was that a keyhole surgery?
They did the laparoscopy.
Yeah?
Yeah.
So laparoscopic. And then at that point, surely they would have seen a football-sized fibroid.
So, rewind. So, I had the fibroid the whole time, but the doctor that I had said that the fibroid was not going to be an issue because it was not interuteral, I guess. It wasn't messing with my uterus at all. But that's how I ended up with the doctor that I had, is because my OB saw the fibroid and she said it was big. So we did all these treatments throughout the years, and then we decided that we was going to go ahead, based off another doctor, that we would go ahead and remove the fibroid. So we had the fibroid scheduled. for removal. I think it was July. It was July, and May is when I found out I was pregnant.
Understood. Okay, and this was 2017.
Yes.
All right. And then, so obviously they dealt with the priority at that point, which was the ectopic pregnancy.
Yes.
And then you said you think it was a month or two afterwards, and then they removed the fibroid.
Yes.
Okay, and how was that done, Danisha? Was that also by the laparoscopy, or did they have to cut you open?
That was laparoscopy as well.
Laparoscopy as well, so laparoscopy as well, and that was then a myomectomy. And in terms of the size, because I had been seeing, in the records I could see that over the years they had seen these small fibroids, and they grow slowly over time, but the last measurement that I'd seen was like 3.3 centimeters. Obviously this fibroid had changed very, very drastically if you're saying it was a football size.
It was the size of a soccer ball is what they said.
Oh, wow.
I tried to get my records, but of course they did not send them.
That's okay. And then following on from that, obviously surgery, I mean obviously yes, that was 4 years ago. Would you have had an ultrasound, say, in the last maybe year or 18 months, Danisha?
I had a HSG and I had a ultrasound when did you go? Last May. Not 2020 May. I had an ultrasound.
2020 May, and the HSG, what did that show?
The HCG showed that the tube was open and the uterus was full uterus.
Okay, so the right tube was open.
What did I say? HCG? I mean HSG.
Yes, I don't remember what you said. I thought it was HSG. So your right tube was open. Okay.
Right tube was healthy, and the uterus was healthy as well.
Uterus was good. Okay, and then so between the HSG and the ultrasound, perfect. Okay, excellent. And then obviously I have some blood work, that has been done as well. Now, apart from just to sort of circle back a little bit on this one. You're 37, your periods tend to come every month, so you tend to have a shorter cycle, more like every 24 days, is it?
Yes, 24. Sometimes it's 27, but right in that range.
In your past, you've had, initially they were using words like polycystic ovaries and things like that, and you've had an infection treated, but in other words, the only gynecological surgery procedures you've had done would be your fibroid operation in 2017 that we talked about, and you also then had some polyps in 2016, and that was a hysteroscopy or a DNC, or both?
He did both.
Hysteroscopy, DNC, okay. So that was taken out in the workup, and they had known you had fibroids, but the evaluation was that they were not at a size or location that was seemingly impacting things, okay?
Yes, according to that doctor.
That was obviously then a different opinion than 2017.
Yes.
Okay. On a medical front then, any medical problems that you know of? So hypertension, diabetes, or are you otherwise healthy?
100% healthy.
Perfect. In terms of operations, apart from the ones that we've just spoken about, any other surgeries?
Not related.
Two laparoscopies, one for ectopic, one for fibroid, and then one hysteroscopy DNC.
Yeah, not anything related to down there.
Okay. All right. Any operation that requires a general anesthetic?
Yes, I had a fibrocystic tumor removed from my left breast.
Yeah, so left breast, that's fine. Okay, and then in terms of allergies, you were allergic to latex, but no medications that you know of?
Latex and shellfish, that's it.
And shellfish, okay. All right. Oh, this is your turn for the hot seat. You can
Okay.
You can beat her. Okay.
I'm ready.
So you're 40. It doesn't look from what I see on the form that you have any significant medical problems. So again, things like hypertension, diabetes, all of that's okay, is it?
Right, it is.
Okay. Any operations for you, or are you leaving that up to her?
No operations for me.
Good. And then in terms of, you don't have any kids from previous relationships, but obviously we're talking about these, all 5 pregnancies were natural conception.
Right, no kids from previous relationships. That's correct.
At least we hope, huh?
What?
What was that?
Nothing.
I said, at least we hope, huh?
That's right. And then now is not a great time for that. I can assure you. There were a few times I hold my breath, I can tell you. So obviously, in terms of, this is a long history, but equally where you have been able to get pregnant through normal intercourse before. Now, there is a number of different things from your history, Danisha, that have obviously played into this.
Yes.
Obviously, that fibroid that was there before probably was part of what was creating that slightly different shape for your uterus, and it probably was obstructing what would be your right tube. That meant that when they image, because remember when we put the dye in, sort of think that we're seeing an image which is just what the inside sort of shape looks like, and looking at the tube.
Right.
So they obviously interpreted the image they saw as, oh, this is a unicorner uterus, because there would have been a restriction on one side with the absence of the tube being visualized. And they thought, oh, she has a unicorner uterus, which occurs in about 1 or 2% of the population, and then basically and a patent left tube. Now, if that was the case, then that carries an implication where, yes, it will mean that technically you will only be able to achieve a pregnancy on left-sided eggs, which reduces and may explain why someone takes slightly longer to get pregnant.
Right.
Okay? It also has an implication to the pregnancy once you are pregnant with an ongoing pregnancy. Less of an implication into the explanation of recurrent miscarriage in the first trimester, and I'm going to come to that separately, okay?
Okay.
But a unicorner uterus technically does carry an implication to what would happen in the third trimester, because those uteruses don't have the capacity to expand in the same way for term pregnancy.
Right.
So premature deliveries in unicorners are much more common, okay? And where that feeds and circles back into what we're going to come to in a few minutes is, those are patients that we definitely want to put a single embryo transfer, okay? And we don't want to be considering twins.
Correct.
Now, obviously, this whole story unfolded a bit more when you ended up then going to surgery and they were able to see there is a big fibroid. I mean, the evaluation obviously showed that before. And once they removed that fibroid, suddenly the right tube was visualized.
Right.
Okay? And that almost certainly tells me that was obviously compressing the right tube. And obviously the border of the fibroid. Then I'm going to come back to your markers and your age, Janisha, and your history. If we had an under 35-year-old, so I talk about 8 to 18 eggs being normal. Let's pick a 32-year-old. The average number of eggs at 32 is probably 16. Now, if we had a 32-year-old getting 16 eggs, maybe 14 fertilized, it's not just that we get more, it's that there's more that keep developing, so that patient might produce 6 or 8 blastocysts. Now, inherent to the quality of those eggs at that age is that if we just chose one and transferred, she probably has about a 50% chance of being pregnant. If I push that up to 2, that would probably climb to 70 or 80%, but we're going to see a 35 or 40% twin rate, okay? And about 2/3 of patients under 35 will make more embryos than what are transferred. Now, going to the other extreme, suppose I was now saying, well, what is an average answer at 42, not 32? Things are very, very different, guys. So by then we're probably an average of 6 eggs, but what there is a massive difference of one lady versus another. So some might still produce 12 eggs, and some may struggle to produce 2. When you look at embryos at 42, the number that fertilize, the number that keep developing are going to be lower, okay? And it really does come down to how many good embryos do we see. And if you look at genetic evaluation, about 70% of embryos at 42 are genetically abnormal, okay? Fit in with why it is that we, for years, we're putting in more embryos and not seeing pregnancies to the same degree. Now, let's bring this back to yourself. So you were 37, and Janisha, that's a whole lot better than being 42, okay? We lose about 8% per year after about 35, but there's no significant difference if you look at patients at 28 or 32 or even 34, okay? Now, in your past history, previous pregnancy always confers an advantage, okay? So even though they have not been ongoing pregnancies, Janisha, they still confer an advantage that you are more likely to be producing eggs that are capable of making pregnancies, okay? Now, what has been detected is that your AMH level is lower. So where does that number feed in? Well, how do we interpret that number, what it really means? So this is a blood test that's trying to tell us how is this lady going to respond, okay? And imagine that from a medical perspective, I titrate the dosing protocol with your age and markers. So very simply, you go from low dose meds at 30 to high dose meds by 40, okay? So at 37, somebody would typically have been on a sort of a medium high type dosing and expecting that 99% of the time that person would make 8 to 18 eggs. Okay, and if you said average for your age, probably 12 to 14 typically. Okay. Now, AMH levels help us pick out the 2 extremes of the 1%ers below or above. Now, below is not a danger, but obviously our worry is if we could predict the person at risk of producing too few, can we modify the dose and then see a normal number, which is obviously the goal. And an AMH level less than 1 is linked with a higher odds of not getting as many as 8 eggs. So your AMH level was 0.48, so 0.5, okay? So yes, that is less than 1, and that does raise that flag. Now what it also does is, because AMH also predicts the risk of too many, ovarian hyperstimulation, Darnisha, is probably the only danger of IVF. You don't want someone to make 50 or 60 eggs. A, sometimes, B, it doesn't do the best thing for quality. But we know with an AMH level like yours, you cannot make that excessive response. Okay? So what it means is that I'm going to go to the highest dose protocol because I know she's not going to hyper-respond. And in many cases, Anisha, we might find that you do slip up into the normal range of the number of eggs. And the way you look at it is every egg is a chance. Okay? So, you know, as I said, at 0.5, somebody must be aware that, yes, they may get lower numbers. And I think I tend to paint the realistic expectation of, yeah, you may get 4 to 8 eggs rather than getting, 14 eggs like many people would. But equally, with your previous pregnancy record, you just don't know. And AMH cannot be perceived as being perfect, okay? I have seen patients with an AMH level of 1.5 produce less than 8 eggs. And I've seen patients with an AMH level of 0.2 produce 23 eggs, okay? So these things help us. Now, the other marker that was in the records was your functional marker, so to speak, your FSH test. That was normal, Danisha, and that's actually quite reassuring as well, okay? So that basically when they looked at that, your brain is still functioning at a normal number of FSH. So that should be less than 8, and it was 6.5, okay? Often if you have significant reserve issues, you will see the FSH begin to climb. And often it might have been the marker that went up first, okay? So basically, I think the way we interpret this is that you should respond, but we're going to compensate by putting on higher doses because it looks like you'll probably need that. But importantly, it would be then to create those embryos and find hopefully the good ones. Now, let's go then to how do we select embryos. And for every single couple in this day and age, you choose between morphological selection or genetic selection. And I want to go through the two, what they do, maybe reasons why we might consider one over the other. Okay? So with morphological selection, what we do is we don't do anything invasive. This is what's been done for 40 years. You observe the embryo, okay, and you then, what changed in the 40 years is when you chose them. So we used to choose on day 2, then we chose on day 3. Now we choose basically on day 5 in most cases. And ultimately, basically, you are generally going to consider putting in more than one, okay? So if you're under 35, maybe we do put only one. But for most people at 37, Darnisha, we would be looking at 2 nice blastocysts for transfer. With that, given a higher chance of pregnancy, but with that also taking a risk of twins, okay? And that risk is not insignificant. About 25% on average is what the twin rates are with IVF, okay? Now, the alternative option is genetic. So we've understood for decades that you can have an amazing looking blastocyst that's not normal, okay? And essentially, science now allows us to get that information from an embryo. So it does mean culture to blastocyst. It does mean that we do something invasive. We biopsy the embryo, we remove 4 to 5 cells. You freeze the embryo. The cells go to genetic testing facility, and we get a report back that says, okay, we've got 4 blastocysts. Well, number 1 and number 4, for example, are normal. We then focus on transferring one of them. Okay. The pro argument for genetic testing is suddenly whether someone's 25 or 45, the odds become the same, which allows a more effective single embryo transfer rate, which is 60 to 70% for a tested normal embryo. Okay. Now, that's a statement that's, well, it's true, it's very misleading. If someone's 25, they're going to make a whole pile of normals in one go. If someone's 45 and has a normal embryo for transfer, they may actually have taken 5 rounds to get that normal. But technically, the day of the transfer, yes, they have the same odds. Okay? Now, when you look at genetic testing, it has 2 significant practical impacts. The first is on logistical planning, and the second is financial. With logistical planning, it means that if you're doing morphological, imagine that your egg collection and transfer, Darnisha, occur in the same menstrual cycle. So from that first scan, you're here for 2 weeks, and everything happens within that 2 weeks, okay? If we're doing genetic, it doesn't, because remember, it's not all about the embryo. We create the embryos, we grow them to blastocysts, but we then biopsy, and we freeze the embryo. And even though we might get that report back only a few days later, we can't just thaw embryos and put them in randomly. You have to be back at your receptive window, okay? So what it means in practical logistics is the first trip is shorter, but then you return for your transfer once we have the normals.
Okay.
And that return trip is very short. Technically, you could fly in the night before and have your transfer and fly back out the next day, okay? At least in the good old life before COVID, we could, okay?
Mm-hmm.
So that's in terms of that first step in logistics. The second step is in terms of finances. Yes, they will do detailed estimates from here, but a genetic test in addition does add about $2,000 US as a flat fee and $250 per embryo biopsy. So it's not an insignificant add. That brings us quickly to the, well then, why, do we do this for everyone? Are there some that will benefit more than others? If you have an under 35-year-old with no history of recurrent miscarriage, no history of recurrent IVF failure, the couple are prepared to put in 2 embryos, and medically it's okay to put in 2 embryos. Truth is, genetic testing doesn't change your status, okay? On the other hand, if you had your 42-year-old that she had a good reserve, then sure, immediately, straight off the bat, we know that genetic testing will help the process and will improve the odds, okay? As a general, the further back you go from 42, the more grey the question becomes, Tarnisha, and it comes down a little bit saying, well, how many embryos are they likely to make? Now, in your history, your rare reserve would suggest that you will not get as many blastocysts, simply because you're probably not going to get as many eggs as some people might, okay? But at the same point in time, on the pro argument for genetic testing would be that you have had 4 miscarriages at young ages. And that may be because you're, for some reasons, even though they did your karyotype, that there's more abnormal embryos. And so that would tip in a pro direction. But equally, it's not that it's black and white, okay?
Will stress be a factor in that during those times because it was real high?
Not
really.
When we look at stress, Danisha, stress is never helpful.
Okay.
Do I think that stress causes infertility or causes miscarriage? No. I can see that your doctor's notes referred to that if you had another miscarriage, they were going to do genetic evaluation of the specimen. Obviously you didn't, you ended up with an ectopic pregnancy after that, where that comment was made. But, we know that in recurrent, and if someone like you, they've done your basic workup for reasons why someone might miscarry. Now, they haven't found anything dramatic. Back in the early 1990s, there was a school of thought which was, well, do we try empiric treatment? And in that case, what was done was the patient was put on something called the HAS regime. Heparin, aspirin, steroid is what the acronym stands for. Right. And these days, heparin is a low molecular weight version, so it's Lovenox. It would be the most common trade name for you. Okay? And I don't know whether they'd ever tried doing any of that. It didn't look
I'm
like
doing the aspirin now.
You've done the aspirin.
I'm doing it now.
Yeah, okay. And, the logic is that it does treat more than one thing in this sort of arm because, there are a small number of patients that their body isn't letting the implantation happen, okay? And that might be why the miscarriages happen. Now, again, as I said, it can just be that the embryo isn't developing. But I think for you, given your age and your young age for this, Darnisha, there's no degree that I would certainly be covering that base at any embryo transfer, whether that is that you take the approach and say, look, with these miscarriages and with everything, we would want to do genetic evaluation to know we have a normal. And then once we find that normal, we would then treat you and plan that transfer. Equally, because of the fact that you're 37 and because of the fact that you have a lower reserve, Darnisha, it's not that genetic testing is the only way forward. I think that the other option is to say, look, we may not get as many blasts here, but, you've now had the big whopper fibroid out. Mm-hmm. We don't have a uterine anomaly. We can put in 2 embryos, and is the quest forward that we do put 2 embryos in, taking that tiny risk of twins, or that risk of twins, but now that they understand the uterine factor, that will be less of a question.
Right.
And in that case, then yes, I would put you on the HAS regime. In terms of if your screen is negative otherwise, the idea of adding in natural killer cell assessment and treatment is less likely to be a concern. Natural killer cells are one of our subtypes of white cells that do regulate pregnancy implantation. And for patients with a recurrent miscarriage and importantly recurrent IVF failure, this may get dialed upwards a little bit, Danisha, where for some reason our body isn't letting that step happen, okay? But, you know, we know that if we're going with the empiric treatment regime, that actually treats an enormous percentage of those embryos as well, or those problems as well, okay? So you've got quite a few segments of your history, as I said. You know, the background of recurrent pregnancy loss, but equally with a big fibroid that just seems to have been extraordinarily big compared to what they were seemingly seeing, okay? You know, plus the fact that obviously the good thing is that the uterine factor has been clarified. A, it's been removed from the fibroid, and B, we now know that you did get born into this world with 2 tubes and a normal sized uterus, okay? Alright, so I know that's a lot of info, guys. Typically we don't have to quite gallop through every branch there is in fertility for this. Have you any questions for me?
Do you have any questions, babe? So back to how long you said. So you're suggesting that we do the 2 trips?
With recurrent miscarriage, Danisha, there is a data to support that you want to basically genetically evaluate.
That's fine.
Because once you find that normal embryo, it really does set a different pitch of what the expectation is, okay? And through this, we were going that route, we would definitely be empirically treated. And, you know, you might say, well, at that point, do we expect someone to be fine? Suppose we found 2 or 3 normals. You might say, well, let's do the first one with the HAS regime. But if we're not, we would definitely test killer cells before we go forward again. Or if you found only 1, I'd probably do the full testing before we transfer.
That's fine.
But because of your 4 miscarriages at a young age, you would be a candidate that they are going to do genetic testing.
Okay, so that's fine. So the first trip, I just need to know how long the first trip. My husband is military,
You're
so
about 10 or 11 days, yeah. Sorry.
Okay.
So, you're military, is it?
yes.
Mm-hmm.
And then
Yeah.
the second trip will be
The second trip we only need you, because at that point, remember, Danisha, the embryo is made, okay? So we don't need Otis at all that trip, and that second trip is very short. So, you know, literally before COVID quarantines and things like that, you literally would have flown in the evening before, had your transfer and flown out the next evening.
okay.
Okay? Now, question, are you both vaccinated?
Yes.
Brilliant. Okay, so that means that your travel journey is definitely a whole lot easier. If somebody's unvaccinated, they still have to quarantine for 5 days with a retest. Okay, if somebody's vaccinated, you are tested on landing as it speaks right now. At some point, I'd imagine that's going to go, but we don't get to control that decision. But then basically, it's like a 1-night quarantine rather than anything like a 6 or 7 night quarantine, which is what it would be if you're not vaccinated.
Okay. And with okay. So I saw that you all had, which my husband has a meeting, so I'm trying to get to the finance part of everything. So we got $2,000 for the biopsy.
The finance part, Danisha, they're going to do a detailed estimate.
Okay, perfect.
Now when you have your full history and we have a plan of action forward, I'm going to basically get them, they're going to do a follow-up, they're going to get you detailed estimates of costs, and then they're going to start to plan the practical side with you. When can this happen?
Okay.
They're also going to send you a sort of a prospective timeline which helps make sense, because then you can see how all those things I just described fit together.
Okay.
Okay? Later today or tomorrow?
Okay.
And ultimately, in terms of detail goal, you should certainly have that by tomorrow, and then they will start to talk about when are you looking to go forward. You're vaccinated, which means that they can plan. You know, I mean, technically you would make it a cycle before the end of the year at this point. We're now the end of September, but that could be a start of meds in late November, early December. You know, would be an option. But equally, is a month going to make a difference? Then you should know if A, B, and C reasons why you look it makes sense to plan in January, then that is okay as well.
I want to do it way before January.
Okay. So I'll let you know when you're ready to go. And
Yes, we are ready.
And sometimes they've sent you stuff and I can't see that. That won't necessarily be what I can see.
Okay, yes. Tell them as soon as they get us some dates.
I will convey a little bit of info. Okay?
Okay.
All right. Well, look, it was lovely to talk to you, Danisha. I look forward to meeting you in due course, okay?
Thank you so
Thank
much.
you.
We look forward to seeing you.
You're welcome. Take care. Bye-bye.
Bye-bye. 45 minutes. Okay.
So
I
That's cheap.
got a little emotional. I did. Oh, this talking. Don't talk smack. I feel good because she said that my FSH number was not bad, so it could have it probably could have been off my AMH, but I felt better. I'm just ready to move forward.
We'll get the next call here soon.
And the battery's dying.
Yeah.
We've been
There's a natural shape you expect, which is sort of like a broad triangle upside down. And that fibroid may have changed that where they interpret it as that unicorn uterus.
okay.
Now, it also almost certainly tells me that that fibroid, as it grew, would have been likely compressing that tube. Okay? When it does that, even though they were clearly able to save the tube from the surgery, okay, it does mean that that likelihood that that tube may be functional is a lot less than if this whole, but I pieced your puzzle together, that wasn't the background, okay? So when we have fibroids themselves can affect fertility by, they can do it directly or indirectly. They can pinch tubes and mean that the tube is not working, and they can technically do that to both tubes. They can interfere with the cavity. So when it comes to fibroids and the need to remove them, imagine that it's down to size and location largely, okay? If we have a fibroid that affects the cavity, then, if it's smack in the middle of the cavity, even small fibroids technically, Darnisha, may need to be removed, okay?
Right.
On the other hand, if you have a fibroid that's sticking out, if you like, outside the womb, they are allowed to be much bigger without likely causing an impact. Yes, they may be felt by the patient, and yes, they will grow with the pregnancy, but they're probably not going to complicate it, and unless they're growing near to a tube, they may not actually stop the pregnancy occurring. Okay? Now, the biggest other group of fibroids are the ones that sit in the wall, and they can project inwards, which are called submucosal, or outwards, which are called subserosal. And basically, again, it comes down to the size, whether it projects and distorts the cavity or not, and that would have been a little bit of trying to explain to you why your doctor that was evaluating you back in 2015 or 16 was obviously, and I can see from what's written in the records you've said, that the assessment was that this is not likely to be a fibroid that's affecting the cavity.
Correct.
Now, while most fibroids do not grow quickly, you get some that do, okay? And that in itself, it's certainly joining the dots between the records where I have, which were sort of up to the ectopic pregnancy in what was sent, and then to imagine a soccer ball just seem, oh my goodness, this seems quite different to what I would have expected,
Right.
would have seen, okay? But basically, obviously, importantly, a fibroid the size of a soccer ball clearly needs to come out before you're going to be pregnant, okay?
Right.
So the fact that that's been done is great, okay, and the fact that they've obviously scanned and they've evaluated everything else, that's good. And weirdly, Darnisha, you can have patients that have lots of small fibroids, and they're really challenging, okay? The patient that has maybe one or two bigger fibroids will always have a better outcome if we've taken them out,
Right.
okay? All right, so that's just to touch on the fibroids, but as I said, it does fit that the uterine anomaly is actually not genuine. It was because of the development of the fibroid, which was misinterpreted as a unicorn uterus without a right tube, but obviously we know now that that's not true, okay?
Right.
And why is that important to hammer this out? Because of the impact to the future decision of transfer, okay? So we know now you have both sides of your uterus, but this was what they misinterpreted a few years ago,
Right.
okay? Now, circling back then basically to where we are now, your left tube, which would have been your good tube, not compressed by a fibroid, was obviously lost in the ectopic pregnancy.
Yes.
Okay? The fact is you haven't gotten pregnant since that ectopic pregnancy. And that's not terribly surprising. Even though your HSG may show that that tube is physically open, Darnisha, I would not interpret that as being likely that that tube is functioning. Okay? Because it clearly was squashed with a fibroid, which is why they thought that you had a unicorn uterus in the first place. And at the end of the day, ultimately, is likely not to be functional, and an HSG doesn't detect function. It just physically looks at the pipe, so to speak. Is it open? Is it normal in caliber? Okay? And I think that equally, I would not have sent you straight to IVF in 2017 after they'd done the surgery, but you would have said, look, you know what, this is always a concern if the fibroid's been in this position with this big fibroid, or rather the tube's been in this position with a big fibroid. but you never know, maybe it will happen because you guys have been able to get pregnant before, okay? But obviously adding a few years to this, and we're now in 2021, you know, as I said, the assumption here is that there's a strong suspicion that that right tube remains because it was likely squashed by the fibroid, probably is not functional, okay? Now, coming back then also staying just with the female, obviously in your past you've also then had, so going through, you also had an abdominal pap smear and a leak procedure in 2001, correct?
Correct.
Do you remember what level of abnormality it was, Danisha? Was it a 1, 2, or 3?
Oh, honey, that was in.
I'm not sure.
It's probably a 1. It wasn't severe at all. Like.
Okay, so it was mild. Okay, and then since then, pap smears have been okay, have they?
Correct.
Correct. Okay. That's fine. Now, I can see that when they work up back in the 2015 and what have you, they were obviously focusing on looking for reasons why you might be miscarrying more frequently.
Correct.
So let's talk about recurrent miscarriage, okay? When someone has a miscarriage itself is a common complication of any pregnancy. About 15% of all natural conceptions actually miscarry, okay? And, you know, another way to put it is that 1 in 4 women will have a miscarriage at some point. When we look at when the miscarriages happen, the vast majority, like yours, occur in the first few weeks of that pregnancy. And the truth is 98% developmentally occur within the first 8 weeks, so within 1 month of the pregnancy test, doing our 1 month of the missed period, okay? Many of which might be even before we would technically normally be doing that first scan, and such as yours. And if you look at the various reasons why miscarriages might happen, if you just take a single miscarriage, the odds of it being that the embryo makes an error is probably 90 or 95%, okay? There are about 5 to 10% that may be for other reasons. Maybe someone had a big bleed, maybe someone had a nasty fever, maybe they had, you know, these are things that might happen, okay? And when someone has a miscarriage, it is not normal practice to do a whole lot of investigations, because we know that the odds are the next pregnancy is going to be just fine. Now, if someone goes on and has another miscarriage, the statements are roughly the same. But certainly if someone goes on to have 3 or more miscarriages, that now is a diagnosis called recurrent pregnancy loss. And we know that if we start doing tests, we are going to find a more significant percentage of those patients that there is another factor. Okay, and I can see that they obviously did that workup for you by the results and the notes that you've sent. So they looked at reasons why you might have had thrombophilia. They looked at to see that you had both your normal karyotype, that you had the right amount of DNA in the right place. Because whereas 90 to 95% of single miscarriages are genetic, only about 8% of recurrent miscarriages are genetic. So yes, someone can have 3 strikes of bad luck, so to speak. But what we're really looking for in the recurrent miscarriage is, do we have something called a translocation, where somebody has maybe a little bit of chromosome 10, for example, stuck on number 15, okay? And while it makes you genetically normal and healthy, when you go to pass your gamete on to the egg or the sperm, you will create a much higher percentage of abnormal embryos than you might expect for your age. And that's why you see the recurrent miscarriages in those patients. And those are patients that these days, yes, you can keep trying naturally, but those are patients that we do have significant benefits to genetic techniques in IVF to be able to find the normal embryos quicker. Okay? But you had normal karyotypes, you had normal thrombophilias by the look of what you can see. The other thing would have been the uterine evaluation, which obviously was what they thought was a unicornus, and now we know is not the case. Okay? Unicornus don't usually cause recurrent early miscarriage. Your worry is much more later on in the pregnancy.
Correct.
Okay? So obviously that's just in terms of recurrent miscarriages, and yes, they were at a young age. So while, you know, if somebody has a few miscarriages at 40 and 41, you know, Danisha, when we work backwards, you know, in 2010, let's face it, you were still in your, just over your, you know, in your latter 20s when you were able to get pregnant, but yet were miscarrying early 30s for the others, okay? So that is a factor that we're going to take into how we plan forward, okay? Now, the other thing that they had identified back at that point was, Otis, for yourself, there is a male factor in the parameters of the normal numbers of sperm that these women, okay? So, obviously, when a guy produces sperm, first of all, every ejaculate is going to have slightly different numbers, okay? Now, clearly, because you guys have 5 natural conceptions, we know that these sperm are capable, and they're obviously present in sufficient numbers to achieve natural conception too, okay? But the 2 samples I have, one was written in the narrative where the key information was written, and one was the one that's in the records you uploaded. You know, both were lower numbers of sperm in concentration. And significantly, the last one I have the full record, which is that the number of highly progressive sperm is, so the more recent sample was about 13 million concentration. It should be 15 million or more, so not majorly reduced. But then only about 26% progressively swimming, which should be over 32%. So again, very mild reductions there. But in both samples, this one and the one back in sort of the 2016, what was significant is that the number of ideally shaped sperm, which to a very trained eye is the majority, believe it or not, you were at 1% normal forms. Okay, and technically the WHO criteria would be 4% or more. Okay,
Right.
so believe it or not, most men's sperm, there's an enormous percentage of sperm that are not perfectly shaped. Okay, but there's some guys that will be reduced further, and that definitely can pose a challenge. And if you think what really matters on the ejaculate, how many normal swimming sperm are they? So when each thing goes down a little bit, then it can have a much greater knock-on impact. Now, with the background of this 5 natural conceptions, we clearly notice that there must be days that the samples are better than what those 2 results show, okay? Because it would have been far less likely that they would have necessarily achieved natural conception. But it's not impossible. I think that's really important to appreciate, okay? But of course, we're not going to ignore the male factor element in what we're doing going forward. We would want to choose a normal, strong swimming sperm.
Right.
Optimize that every egg has its best chance of fertilizing, okay? So, that is another element to your whole background history of the 14 years. I think you're covering at this point, guys, most of the chapters in the background of fertility, okay? You've got miscarriages, fibroids, question about uterine anomalies, which obviously have been clarified, and a male factor in there, okay? Now, obviously, coming back then to your age journey show, one of the challenges for us ladies that we're born with all of our eggs, we don't make them new. And as we go through life, the number and quality are going to change, okay? We will see this play out in natural conception, we will see this play out in IVF conception, that the odds per month in natural conception in the late 30s, early 40s is going to be different than when we're in our late 20s, early 30s. When you look at the world of IVF and you look at the number of eggs, the number of embryos that keep developing, that again will also be different, okay? And again, we're not going to have the same ovarian capacity at 37 that we had at 27, all right? So I'll come back to your ovarian reserve markers as we talk through, but yes, they have also identified that you have a lower AMH level. And what that really sets is really a priority of saying, look, let's move these guys forward now. Let's not wait till they become the 42-year-old.
Correct.
Okay? And granted, let's put this in perspective. We've all been dealing with a global pandemic as well, which means that the whole of medicine, for non-emergent things, it's sort of grind to a lower pace of anything progressing forward. Okay?
Right.
So basically with IVF, what IVF does is it allows us to get the egg directly out of the body. So if we have a tube that's not working, which is what I suspect is the case here, then it bypasses a need for a tube. It also allows us, Donisha, to extract eggs from both ovaries, okay? Because you've lost your left tube, means that any left egg that you release is not going to be of any use to you, okay? But in the world of IVF, it will, all right? In terms then of, once we extract them directly, we then fertilize them with the sperm, and obviously in this case, so it is in this history, we get to choose the sperm, making every egg have their best chance of fertilizing. And then it's a case of culturing embryos and selection and transfer. Now, let's expand on that concept a lot. So, with IVF, or rather, shall I say, in a natural cycle, your body recruits follicles to move forward from the group that you were born with, okay? And imagine that your hormone levels work in a way where you recruit them, they move forward. In most cycles, we probably recruit 15 or 20 for many of our years. And our body allows something called lead egg dominance and negative feedback. And what that means in plain good English is the fact that one egg gets to be the boss. It shuts it down, it stops the other follicles developing, and it means that we protect ourselves, because if a fellow's producing millions of sperm, if we ovulated 15 or 20 eggs a month, we would be in big trouble.
Right.
Okay? With litters all the time, and now we were not well designed for that. Okay? So the lady limits the litter size by producing generally one egg. Okay? But it's not that you use only one egg. You actually have available more than one per cycle. When we use IVF stimulation, this is what we changed, Anisha. We put you on the exact same hormone your brain makes. But the difference is by giving it as an injection, more of those follicles are allowed to continue because the lead follicle cannot control the supply anymore. You are, with basically what you're injecting in our direction. Okay? So we get more follicles. Typically in IVF stimulation we expect to see somewhere between 10 and 20 follicles, and likely you get anywhere between 8 and 18 eggs. Okay? Average being about 12. And clearly that's going to confer a significant advantage of finding good embryos. Now, the way that we plan IVF, just to step back for 1 second, is we plan it from the menstrual cycle before the one we're going to use. And as odd as this may seem, you go on the contraceptive pill for that month. That does a few things, Anisha. Raise your hormone baseline. It gathers those little follicles together to better go forward as one pack. Okay? It also allows the practical side of scheduling, so you know exactly when you need to be here. Okay? And imagine that in your timeline, when they show you this, is going to come a point where you see, take my last birth control pill, and a couple of days later it's going to be, take my first stimulation injection. Okay? At the end of the first week of that, that's when your first visit in Barbados will be. Okay? And imagine that that day we're going to be doing ultrasounds, we're going to look and see how many follicles, what sort of size, do I need to change your medicine anyway, and when do we scan you again. Over the next few days, it'll be multiple ultrasounds, and we should get to a point fairly early on that we say, great, she's got the right size, she's got the right output of hormone, we can now trigger, and this will set the date and time for the egg retrieval. Okay? That is done 36 hours after the trigger shot. It is done with the use sedated, so you don't feel any pain. It takes about 15 minutes to do. It is a day case process. You do spend about an hour and a half with us between being admitted on time, sedated, and sleeping it all off. Okay? And what can you expect afterwards? You will be up and about that evening. By and large, you need no pain relief or maybe needing the equivalent to what you might take for a headache. Okay? Now, going back to those eggs, that morning notice, we would get you to produce a fresh ejaculate. The embryologist will look now for a normal swimming sperm. Choose one of them, and the day after we see how many are fertilized. So the last phase, guys, is very, very much linked to individual